All right, up next is our very own Dr. Who. Recall that she is an assistant professor in the Departments of Emergency Medicine as well as the Department of Medicine, Division of Pulmonary and Critical Care. As many of you know, she completed our EM/IM critical care program. We were fortunate enough to keep her on as faculty, where she splits her time in both the emergency department and our medical intensive care unit. And she is currently the program director for our combined EM/IM program, along with our combined EM/IM critical care program. What Cami will be bringing us up to speed with is Resuscitating for Two. So yet another very tough and challenging critical case and patient population that comes into our emergency department when we have the sick pregnant patient and when we need to resuscitate for two. So, Dr. Who?
Thank you very much, Dr. Winters, again, for the very nice introduction, as always. And as others have said, it's definitely an honor to be a part of the Critical Care Symposium. So I appreciate the inclusion and enjoying my learning today. I hope you all are as well. Getting started, I have no disclosures or potential conflicts of interest. I may be dating myself a little bit with this slide because these shows are a little bit older, but I think this is a relatively common and understandable reaction to when you hear a critically ill, crashing pregnant patient has arrived in your emergency department. The ultimate goal today is that you come away with some knowledge and you feel a little bit more comfortable managing these patients and you're ready when they do arrive. As a brief roadmap, we're going to present statistics regarding the current state of maternal health care in the US. We're going to talk about pertinent physiologic changes that affect how we take care of these patients. And then again, I'm not really going to talk about specific management of very specific disease entities, but I'm going to give you guidelines and tips in terms of managing these patients when they're critically ill. All right, so hopefully this isn't new for anybody, but the United States specifically has a maternal mortality problem. As the years go on, we remain the highest rate of industrialized nations, and these numbers got worse before COVID and through COVID. Now, maternal deaths are defined as death of a patient during pregnancy or within 42 days of pregnancy, of delivery, from a cause related to the pregnancy or exacerbated by the pregnancy, and these don't include accidental deaths. The maternal mortality rate is defined as the number of maternal deaths per 100,000 births in the course of a year. And as you can see, as the years have gone on, our rates have gone up. To put some numbers to it, this is for 2017, 2018, 2019, 2020, and 2021, the most recent data that we have. And as you can see, 32.9, the number has just gotten higher. Why are these numbers so high? Well, so full disclosure, it was about 2017 when all of the US territories, the 50 states and DC, finally everyone implemented what the National Center for Health Statistics started in 2003, which was the utilization of a pregnancy checkbox on the death certificate to indicate that the patient had been pregnant within a certain time frame before death. And so the thought is that some of that uptick has been related to more accurate reporting. But if you think about it, the fact that this number has continued to rise and that we remain the highest rate in developed nations, that should let us know that the numbers aren't conflated or overblown. We have a problem. Again, just sort of highlighting, we're here in the minty colors, that we far outstrip our colleagues in terms of the industrialized world in terms of our mortality rate. 20 times, this is 2020 data, but 20 times the death rate in the Netherlands. It's terrible. And then the other thing that's worth noting is that we also have a problem in which our Black patients suffer disproportionately. This is a trend that has continued through the years, the different colors being the different years here. And you can see again that our Black patients are dying at a rate 2.5 to 3 times that of our white patients in the United States. It may be easy to say, oh, well, socioeconomic status or health literacy. But again, that's not what the data shows. When you look at college graduates, we still have a 5 times mortality rate in Black patients compared to their educated white peers. And this death rate still remains higher than that of white patients without a high school diploma. So this isn't really a talk about racial disparities in medicine, but any discussion about the healthcare of a patient who's pregnant in the United States would not be complete without that acknowledgement. All right, so why do patients die? So this is the most up-to-date data that's been released or compiled by the CDC. So released by the CDC. So it's from 2017 to 2019. And again, this is pregnancy-related deaths, so a slightly different definition. So pregnancy-related deaths are defined as a death during pregnancy or within a year of delivery from pregnancy complications, pregnancy-associated illnesses, or illnesses that were exacerbated by the pregnant state. If you look, cardiovascular conditions, cardiomyopathy, VTEs, hypertensive disorders, there may be some clues as to why these things are higher in the United States. So one, the obesity epidemic. Looking up top here, we're going to go start at 2016 and cycle forward, with the darker colors being higher prevalences of obesity. As the years have gone on, clearly this has increased. And it makes sense that as the higher rate of the population becomes obese, right, along with those things come other chronic medical problems and comorbidities that can make pregnancy more risky. Another trend that we see commonly, and this only goes to 2017, but it stands today, is that the maternal age is skewing older. So it's probably around 3.6% of patients as of the 2020-2021 data, 40 and over. And again, just more and more women are delaying childbirth until later years. And this is, again, a trend that has persisted over time. But also you see that as the age gets older, there's a higher maternal mortality rate in those cohorts. In terms of cesarean deliveries, it's hard to know exactly what role this plays, but it's worth noting that as the years have gone on, this is again from 2020, you have about a quarter to a third of patients undergoing cesarean sections. Now, this rate is deemed by the American College of Obstetricians and Gynecologists as a guesstimation that about 50% of these are unnecessary. The World Health Organization recommends a general cesarean section rate of 10 to 15%, although admittedly there is no specific C-section rate that portends a mortality benefit or change in mortality in a population. But it's worth noting, more obesity, older patients, more chronic comorbidities, putting them through surgeries that they may or may not need may come with higher risks. And then finally, and very importantly, we already know that access to healthcare is hard in the US. Access to maternal and prenatal care is very limited. So the presence of maternity care deserts, so counties in which there are there are no specific OB centers or obstetricians in the county to provide care for their patients, 36%. And then the remainder, there's about 19% of counties with less than ideal access to OB care. So whatever you think about the current milieu, we are potentially going to have a lot more pregnancies, and our ability to care for these patients is not necessarily increasing to meet that demand. So reviewing those things, it's not hard to see perhaps why we might have a high maternal mortality rate. Now, as compared to the slide that I showed earlier, which was sort of all of the deaths from 2017 to 2019, these are specifically pregnancy-related deaths that were reviewed by specific committees whose job it is to look at why these patients died. And this is data from 36 states. And I'm going to point out two major things. One is that mental health conditions holds the top billing. So this is substance abuse, suicide, etc. And then, of course, the following: hemorrhage, coronary disease, infection. The other thing I'm going to point out is that these committees actually went back and adjudicated whether or not, with appropriate medical care, these deaths could have been preventable. And they found that greater than 80% were. So again, we're going to talk about the management of the critically ill pregnant patient, but there is a campaign by the CDC for us as healthcare providers to really pay attention to these patients. In the emergency department, we remain often the first introduction of these patients to the healthcare system, their safety net for healthcare provision. And so maybe if we were paying extra close attention, we can prevent these patients from showing up at our doorstep when they're critically ill. All right, so switching gears a little bit, we're going to talk briefly about physiologic changes that affect our care. I think it may come as no surprise to anyone that pregnancy is a hormonal state. The placenta is an endocrine organ, and a lot of the changes that occur with pregnancy are hormonally driven. So you have lots of increase in your circulating progesterone, which is going to cause smooth muscle relaxation. That includes in the vascular smooth muscle. So you'll get vasodilatation, you get that sort of nadir in the systolic blood pressure around the second trimester, although you should see some increases back to baseline by the end of the third. But this also includes things like mucosal edema, engorgement, slow GI motility, cholestasis of pregnancy, sphincter relaxation, so that gastroesophageal junction, that acid reflux we associate with pregnancy, progesterone, among other things, plays a big role in that. You also have a lot of circulating estrogen, which is responsible for many things, including angiogenesis. So with that edema, you're having capillary engorgement. You're trying to create, to make sure that everything's getting good blood flow. Estrogen also increases the circulating aldosterone. So you get fluid retention of about 1.5 liters during pregnancy. And as we all may remember from medical school, your red blood cells production is not increased to that same demand. So you get sort of this dilutional anemia of pregnancy. Your GFR increases, so you should be seeing lower creatinines and lower BUNs. So something that may not trigger an EPIC or whatever your EMR is as an AKI may actually be one, right? We're usually seeing, in a normal healthy pregnant patient, creatinine is about 0.5, 0.6. And then, of course, if you think about increasing circulating volume, increasing stroke volume, our cardiac output also increases. Again, that 1.5 liters, your heart rate increases about 10 to 20% as a pregnant patient. And so your cardiac output will go up as a pregnant patient to around an average of 6 to 8 liters per minute. So it's definitely the maternal heart is working overtime. And then again, that decreased systemic vascular resistance associated with progesterone. Pregnant patients will experience a physiologic dyspnea. This is not just related to the gravid uterus pressing up on the diaphragm. There is increased metabolic demand and increased O2 need during pregnancy, as well as increased CO2 production. So your actual chemoreceptors will be more attuned and have a heightened sensitivity in order to try to compensate for these things. But you will also have that decreased functional reserve. You get the progestin, you get the relaxin that actually stretches your rib cage, widening of the diaphragm wall, widening of the chest wall. And then again, as the patient becomes more and more gravid, that upward elevation of the diaphragm and compression of the base of the lungs. As patients proceed in their pregnancy, we definitely think about this at around 20 weeks and beyond. You will definitely see some aortocaval compression, but more the IVC and therefore effect on your preload than the aorta. This can be alleviated by a lateral tilt of about 30 degrees. And I think this is a really good pictorial to sort of demonstrate the importance of, if a patient is hypotensive or decompensating, really providing that tilt, whether by laying the patient to the side, wedging them to offload that. In addition, if you're thinking about you need to get IV access in these patients, maybe they're going to need a central line, you're really going to need to place that above the diaphragm in order to avoid any compression, negating or limiting the ready delivery of that medication to the central circulation. Just a little bit about placental physiology. Uterine placental blood flow is about 700 mLs per minute. That's a lot. These placental vessels are already maximally dilated with circulating hormones there, progesterone, nitric oxide, and they don't have any autoregulation. So they change with maternal blood pressure. So things that are going to constrict or decrease blood flow are maternal hypotension, uterine contractions, and theoretically in some vasopressors can act on this as well. But the only way to raise placental blood flow is to increase mother's blood pressure. All right, so on to some nuts and bolts about managing these patients when they come in. Acute respiratory failure. Some things are a controversy and some are not. So high flow nasal cannula in those patients who are coming in with predominantly hypoxic respiratory failure, who are failing nasal cannula, standard nasal cannula, or maybe have a little bit of an increased work of breathing, high flow is readily and widely acceptable as a reasonable option in these patients. Non-invasive positive pressure ventilation historically had come with some warning signs and caveats. Again, those things that increase your pregnant patient's risks for aspiration, right? That slow GI motility, GE junction relaxation, upward displacement of the stomach by the gravid uterus. People were very hesitant to utilize non-invasive. Well, we have several case reports and case series, including those out of after COVID, indicating that if it's an appropriate patient, they're not altered, they're protecting their airway, non-invasive ventilation is a reasonable option and can prevent unnecessary intubation. Again, if you have contraindications, just like any other standard patient to non-invasive ventilation, this isn't who you're going to use it in. You are going to, in some instances, have to intubate a patient. Maybe they're not doing well on non-invasive. Maybe they do have a contraindication. So let's talk about intubation. All those hormonal changes we talked about, that progesterone, that estrogen, makes the pregnant airway difficult. You're going to have mucosal edema. It's going to be more hyperemic and therefore more friable. It's going to be smaller. That gravid uterus is going to press up. It's going to compress the bases of your lungs, and it's going to give you less time in terms of apneic saturation, apneic oxygenation for that patient, for you to get your tube in. So set yourself up for success. When the time comes to intubate, do not wait until this patient is crashing. You want this to be done as a controlled setting as possible. And so when you put a patient on non-invasive, go back early. Make sure they're doing well. And if they're showing you signs that they're not, their work of breathing is not better, their saturations are not improving, their heart rate is still quite high, signs that they are not flying, don't push it to the last minute. Again, make those plans, be decisive, and do it in a controlled setting. This is going to be the most experienced airway provider. This is not going to be, the off-service intern who's very interested in emergency medicine or critical care. Again, it's a narrow airway. You have less time. The fetus does not tolerate desaturation, and the more passes there are through this airway, the more chance that it will be a bloody mess. Set yourself up for success. Similar to the way that we talk about managing obese patients. Note, I did not say pregnant patients were obese patients. You want to maybe keep your patient ramped or use reverse Trendelenburg in order to keep that gravid uterus decompressed off their lungs. Pre-oxygenate them as well as you possibly can. And again, set yourself up for success. Prevent early desaturation as much as you can by providing apneic oxygenation. I'm not somebody who will say everybody needs it, but if you're intubating a pregnant patient, you should apply it to them. And then you're going to start with a smaller AT tube. This is going to be your 6, your 6.5, your 7 in these pregnant patients. All right, talking about oxygenation and ventilation goals. We talked about how, I just mentioned how pregnant patients, we don't want them to desaturate because the fetus doesn't tolerate it well. In general, if you're looking at a normal, standard, healthy patient, right, you have your non-pregnant values on the left here. Pregnant patients with that heightened chemoreceptor sensitivity, that fetal maternal gradient for offloading of CO2, they tend to have a lower PCO2, so standard average non-pregnant person about 40, standard average pregnant patient around 30. PaO2 is generally thought to be the same. But we don't have any randomized controlled trials in pregnant patients looking at what levels of oxygen people should be at. But we have descriptive data demonstrating that we start to see fetal distress and decelerations at a PaO2 of around 60 millimeters of mercury. So our goal in these patients is a PaO2 of greater than 70, which in a patient without shock or major AA gradients like ARDS should equate to a goal SpO2 of greater than 94. When it comes to mechanical ventilation and you're setting your settings, we generally still adhere to lung protective settings, right? Tidal volumes of 68 mLs per kg, a P-plat of less than 30. Permissive hypercapnia, we still utilize. I talked about how the level is generally lower in the healthy population, but you may need hypercapnia, especially in your ARDS patients or your patients with acute lung injury, in order to tolerate those lung protective settings. Again, no controlled studies looking at how much hypercapnia a fetus can tolerate, but generally described up to around 60 is reasonable. So it may be a little bit less permissive hypercapnia than we do in the non-pregnant patient, but you can still do it. And then in general, we recommend a higher PEEP strategy for patients with acute lung injury, et cetera. But again, when you think about needing to recruit those lung bases in the setting of this upward diaphragm displacement, a PEEP of 8 to 10 in your more gravid patients, your more advanced trimesters is recommended. All right, so let's talk about the medications you use once you get them intubated. Most of the medications are fine, and there's a very big tenet of, do what you can to stabilize the pregnant patient, and that is what's going to stabilize the fetus the best. We know to avoid NSAIDs in pregnancy in general due to concerns about, fetal kidneys and amniotic fluid production, as well as concerns about early PDA closure, but most medicines can fly. Ketamine is in yellow here. Historically, it has been used, it has been described. In the past 6 or so years, there's more animal data coming out that with use, there's some fetal neurodevelopmental issues, some behavioral changes after delivery. And so again, these are animal models. So I would say For the setting, if you need to use ketamine, then you need to use ketamine. For a one-time dose for induction, for like RSI, it's probably fine. It's that prolonged use as an ongoing sedative where I would definitely say you should use some caution. And then I realized I did not include RSI medications here. Again, those should generally fly. We do know that etomidate crosses the placenta when used like during time of labor. There is evidence for neonatal hypocortisolemia, but it doesn't really seem to be clinically relevant. Again, using it one time for RSI is probably reasonable. Prolonged use as a sedative agent should probably be proceeded with caution. And then you can use any neuromuscular blockade you need to for paralysis, right? You want it to be, you're intubating a patient, you want it to be successful, you want it to go well. Just be mindful that if there is a perimortem C-section or if the fetus is developing distress, those neuromuscular agents do cross the placenta. And so it's something that you need to pass on to your NICU colleagues or whoever's providing the resuscitation to the new neonate. If they got sucks, it may not last long, but if they got rock, then it may be around a little bit longer. All right, so the management of septic shock, again, broad strokes here. We don't generally get advice from the Society for Maternal Fetal Medicine to provide a 30 mLs per kg, right? The patient's pregnant, so their inherent body weight we're not necessarily sure of. Instead, they recommend giving boluses in 1 to 2 liters as needed, as is indicated. No randomized controlled trials for what pressor to use in septic shock. They extrapolate from general population data and the recommendations for the general population that norepinephrine is generally considered to be the pressure of choice. If you need to add a second agent, you can add phenylephrine or ephedrine. These have been used in delivery. Ephedrine, relatively safe in spinal anesthesia, and has been demonstrated to increase maternal flow without much cost to placental flow. Vasopressin is also reasonable. Again, this is extrapolated from general population data, although theoretically you may see some uterine contractions or some decrease in placental flow with it. And then again, as recommended for the general population, if there is refractory shock and you would otherwise give steroids, pregnant patients should get steroids. In cardiogenic shock, again, randomized controlled trials here, but because of the less vasoconstrictive effects of dobutamine, usually you see some systemic vascular resistance decrease. Dobutamine is the preferred agent over epinephrine and over milrinone for acute cardiogenic shock. Now, in patients who are pregnant, especially if they're presenting with a peripartum cardiomyopathy as the etiology for their shock, there should be an early consultation to cardiology because these patients do well with mechanical circulatory support. So this may mean you call somebody and you get them transferred out somewhere that can do this, but you should call early. This is a good place to state that ECMO in patients who are pregnant is not contraindicated. Whether it's VA for circulatory support or whether it's VV for lung rescue, ECMO is something that should be provided to pregnant patients if it's indicated. Hemorrhagic shock, this isn't really very different from us. You're going to order your massive transfusion protocols as appropriate, remembering to ask for ONEG. Keep in mind that pregnant patients are at a higher risk of DIC. Now, if the patient's exsanguinating, you're not necessarily going to check a fibrinogen level. In terms of all bleeding pregnant patients, we don't see support in the data for empirically administering cryo. But again, if this is a very sick patient who is in shock, bleeding out, go ahead and give it empirically. If it's sort of this like generalized, ongoing, not great, but they're not actively dying and you want to check a fibrinogen level, just keep in mind that in pregnant patients who are bleeding, we have a higher threshold for fibrinogen. We're going to give cryo to get to a goal greater than 300. You can also do things like fibrinogen concentrates, depending on whatever you have available at your institution. Similarly, if you're at a place where thromboelastography comes back fast enough for you to utilize it, you can use it to guide your transfusions or to decide if you have hyperfibrinolysis to give TXA. There was the woman trial that did look at the use of TXA in peripartum hemorrhage and did not see any outcomes difference in terms of the primary outcome of mortality. The caveat would be that the patients who ended up in the women trial they didn't end up being that sick. So if your patient, again, is exsanguinating, you don't have thromboelastography, but they're bleeding out, it's reasonable to trial TXA. And then this is not prime time. This is not for everywhere, but there is description in the literature for Reboa. Now, these are case series. These are out of specific institutions that have a protocol for Reboa in cases of known placenta accreta, placenta previa. These are generally in patients who are planned to go to the OR, are already in the OR, and they have, again, a whole protocol for its use, but it has been well described to stabilize bleeding and the delivery in that frame. So if you're at an institution that uses Reboa or has OB and is a high-risk pregnancy center, you may hear about this. All right, some additional infection considerations. You're going to manage infection like you would in any patients, but just keep in mind that fever during pregnancy has been repeatedly associated with cognitive delays, neurodevelopmental delays, preterm labor, and birth defects. So we're going to aggressively treat fever in pregnant patients. You're going to remember other causes of infection that can occur in your pregnant patients, so uterine infections, listeria if you're concerned about meningitis, etc. And then, however you feel about antivirals in the flu, just know that the CDC and ACOG are recommending treatment with antivirals in patients with a high suspicion of the flu who are pregnant or who have the flu, even outside of that 48-hour symptomatic window. And of course, we just came through a large pandemic you may have heard of related to the COVID-19 virus. We actually got a lot of that here at the University of Maryland. What we know about COVID and pregnancy is that pregnant women are a lot more likely than their non-pregnant counterparts to have severe infection, to require ICU admission, to require intubation, to get put on ECMO, and to die. And their pregnancies are more likely than their non-infected counterparts to result in preterm labor or to require a NICU admission. You're going to treat these patients the same way you would with any other patient with COVID, with your adjusted oxygenation and ventilation goals, keeping those things in mind. Consider ritonavir-boosted ramiprelvir in your pregnant patients with mild illness, especially if they have something else that puts them at risk for severe disease. They should receive remdesivir if they have moderate illness and everything else is appropriate. They should receive dexamethasone if they have an oxygen requirement. And then you probably won't be the people making the decision about tocilizumab or baricitinib, but these are medications that are recommended to be given, if appropriate, in patients with severe illness. Some just other tying things up considerations. You're going to need to consider steroids for fetal lung maturation if they're at a higher risk in these critically ill patients because they are at a higher risk for preterm labor. Now, hopefully, these patients are not the ones that are boarding with you in your ED for a long time, but if they are, and you have the capability, you should have L&D come down and make sure that they're doing fetal monitoring. If you don't have that and you have the capability for ultrasound, you should be doing a fetal heart rate every shift or so. And if you're seeing D cells, that's an indication for steroids as well in this time window because you're going to be concerned about needing either preterm delivery or needing to deliver that fetus early. Of course, you're going to give Rho-D immune globulin for any bleeding or trauma in a non-Rh negative patient. All right, so cardiac arrest in pregnancy, something none of us want to have to worry about or deal with, but something that we need to be prepared for. The 2020 American Heart Association guideline updates for cardiac arrest came up with a few things. One is they made a very clear statement that pregnant patients are more susceptible to hypoxia and that the fetus does not tolerate it. So recommends a prioritization, in addition to your high quality CPR, on managing the airway with an endotracheal tube or a supraglottic airway, with the most experienced provider providing that airway management. If the patient does have fetal monitoring devices on, they make a comment that this generally tends to get in the way and recommends removing it and not paying attention to the fetal process while you're trying to stabilize mother. And then makes a statement that in the post-RAS state, pregnant patients should undergo targeted temperature management with fetal monitoring for bradycardia in the setting of the targeted temperature management. Other cardiac arrest points, some of these made in the 2015 updates. It is no longer acceptable to simply wedge a patient in cardiac arrest. The recommendation is that you manually displace the uterus in order to optimize the CPR quality that the patient is providing. Remember, we're going to get that vascular access above the diaphragm. So in general, we're used to placing crash fan lines because they're the easiest. In your pregnant patients with a very gravid uterus, this is not recommended. You're thinking IO in the humerus. You're thinking IJ, subclavian, IV access above the diaphragm. And then they make a specific statement that you really shouldn't adjust your hand placement in CPR. There have been descriptions in the past literature asking questions about this. The patient's very pregnant, everything's shifted up. Should we do that? The statement is that there is no evidence that that's supported, that practice is supported, and they recommend your standard hand placement. Again, just a pictogram. There is going to have to be somebody during your cardiac arrest whose job is to manually displace the uterus, which is not something we necessarily think about. This is going to be their responsibility. Different mnemonics work for different people. I'm just going to present one that's out there for pregnancy-specific potential causes of cardiac arrest outside of the H's and T's. Some of these may not be pertinent to us if we solely work in the emergency department, but if you're at a place where you need to respond to codes on the floor, anesthetic complications, magnesium toxicity should be considered, bleeding, hypertensive disease, etc. The good news is that you know how to manage cardiac arrest. Pregnant women can get lytics. They can go to the cath lab. We know how to manage trauma and transfuse. And ACLS meds and defibrillation doses are the same. I will make one statement here that giving amiodarone in an unstable, wide, complex tachycardia for ACLS, the benefits clearly outweigh the risks. And if you need to do it, do it. In general, we tend to stay away from amiodarone during pregnancy due to concerns about fetal hypothyroidism and genital defects afterwards. So procainamide and electricity also work just fine if the patient's stable. Amiodarone is not necessarily the first go-to. All right, resuscitative hysterotomy. You have to mentally prepare yourself for this immediately because you have 4 minutes to start the process. Right? So this patient, if you know they're coming by EMS, it may have already been 4 minutes by the time they get to you. You need to prepare yourself mentally. You need to prepare the room that it's going to happen. You need to be ready for to have somebody else resuscitate the fetus once it's delivered, and you need to have the materials that you need. So if you're not thinking about it early on, if you don't practice in your mind beforehand, it's going to be harder to implement this effectively when the time comes. And then again, post-arrest, TTM is recommended, and therapeutic hypothermia, if indicated for whatever their neurologic state is, whatever neurology is recommending, is not contraindicated, and they can certainly go to PCI. All right, so take-homes. Oxygenation goals are higher in pregnant patients. Remember, you're aiming for a goal sat of greater than 94%, or at least a PaO2 of greater than equal to 70. Control your intubation and set yourself up for success. Their airway is inherently difficult and they will desaturate quickly. Keep them elevated as you can to try to offload that pregnant uterus off the diaphragm. Use a narrow ET tube and pre-oxygenate. Use your apneic oxygenation. Remember that resuscitating hemodynamically unstable patients is going to require some lateral tilt. If they're either by wedge or patient guided tilt if they're simply hypotensive, or with manual displacement if they're in cardiac arrest. And again, you're trying to obtain vascular access above the diaphragm. Current AHA guidelines are recommending prioritizing airway management in cardiac arrest with a supraglottic or endotracheal airway, so beyond just bag valve mask. And then immediately prepare yourself and your team for resuscitative hysterotomy. If you have a heads up that this patient is coming, call your OB teams and your NICU teams down right away. Call your ECMO team and get them to come down for possible evaluation as well, if you're at an ECMO institution like University of Maryland. And remember, you guys know how to take care of critically ill patients. For the majority of everything, if you forget everything that I talked about in terms of the care of the pregnant patient, stabilize mom and you'll stabilize baby. Thank you everyone for your time and attention, and I'll look forward to questions during the panel.